Welcome to Podium Perspectives, powered by Vaniam Group.
Welcome to this episode of Podium Perspectives, a podcast that shares up-to-date insights across oncology and rare diseases. Today, we'll be discussing advances in the treatment of diffuse large B-cell lymphoma. I'm Dr. Jason Westin from the Department of Lymphoma and Myeloma at MD Anderson Cancer Center, and I'm excited to be part of this podcast series alongside my colleague, Dr. Caron Jacobson of Harvard Medical School and Dana-Farber Institute.
Thanks for the warm introduction, Dr. Westin. In today's episode, Vaniam Group has brought us together to cover the highlights from ASCO and EHA 2026 and their impact on the treatment of diffuse large B-cell lymphoma.
Great, let's dive in. So at ASCO and EHA, we saw results of a brand new phase 3 trial in patients with newly diagnosed large B-cell lymphoma called the Frontline trial. And Dr. Jacobson, I'd love to hear your perspectives on this trial. The full title is a phase 3 study of tafasitamab plus lenalidomide and R-CHOP for patients with newly diagnosed diffuse large B-cell lymphoma. What were your key perspectives on this study?
Yeah, so this is actually notable because it's really only the second randomized study that documented an improvement in an efficacy outcome, specifically progression-free survival, over R-CHOP for first-line diffuse large B-cell lymphoma. This is a little bit different than the other study, which is the POLARIX study, which established polatuzumab, R-CHIP, as a new potential standard for frontline large cell lymphoma. The difference is, in this study, patients had to have an IPI of 3 or higher to go on the study compared to POLARIX, which was 2 or higher. And the other difference here is that the schedule becomes quite different for patients who are getting treatment. So tafasitamab is a CD19 monoclonal antibody, and it's been approved in combination with lenalidomide in large cell lymphoma in the second line setting and beyond for transplant ineligible patients. And now it's being combined with a backbone of R-CHOP for frontline large cell lymphoma. Tafasitamab is given actually weekly over the course of the 6 cycles of chemoimmunotherapy, and lenalidomide is actually given at a fairly high dose at 25 milligrams on day 1 to day 21 through each cycle. So I think this does really sort of change the bar for which you need to see an improvement, given that it's going to be more chair time for the patient, more infusion time for the clinic, potentially more side effects for the patient. But they did show that there was an improvement in overall response rate and complete response rate. At the EHA, in the EHA abstract, they actually added some data regarding MRD negativity, and there was a significantly higher rate of MRD negativity at the end of treatment for the Tafa-Len R-CHOP arm compared to R-CHOP, even higher than the sum of the partial responses and complete responses for the Tafa-Len R-CHOP, which did suggest that there was a higher rate of false positive PET scans at the end of treatment for that group. And it did show a progression-free survival benefit that was fairly significant, similar to what we see with POLA R-CHIP compared to R-CHOP, with a 24-month progression-free survival benefit of about 71.1% versus 62.9% in the control arm. So that's a sizable benefit. They did not see an overall survival benefit, although they did see a slight trend in an early separation of the curves in favor of the experimental arm. There was some more toxicity, as we might expect from the addition of a CD19 monoclonal antibody, as well as higher dose lenalidomide to R-CHOP, with more grade 3 or higher adverse events, more infections, even in some cases more fatal infections and more cytopenias. It did not appear that there was a reduction in the sort of dose intensity of R-CHOP that they were able to give, which is very important, I think, when we're talking about curative potential with a regimen that has such high cure rates. But I do think that the lack of survival benefit and some of the toxicities is potentially going to make this a regimen that's a little harder to fully replace. So then I might find myself asking, so who are the patients that I'm going to give this to? I'd love to hear your thoughts on this. One interesting thing about this trial as opposed to Polarix is that the benefit was seen in both the GCB and the non-GCB patients. So maybe for those high-risk GCB patients, with the double and triple hit lymphomas or GCB, IPI 4 and 5 lymphomas, this might be a good regimen to pick over something like Pola-R-CHP, but then for your ABC patients, you may still pick Pola-R-CHP. I'd love to hear what your thoughts are on that.
Yeah, I think that's a great analysis, and the lack of cell of origin being relevant in this trial, I think, is notable. And so, either if you have a GCB, large B-cell lymphoma, or if for some reason your pathology team cannot assess cell of origin, but the IPI is high, that you could consider this regimen. It is a nice improvement in a high-risk population, and so I do think this has a high potential to be approved and used and be something that treating doctors need to be aware of. But as you mentioned, there are some limitations.
I think the next limitation may be that there are a whole host of other frontline studies that are being done with some of our most active drugs, specifically the bispecific antibodies. So I wonder, we did see some very, very early results of the Olympia-3 trial, which is the frontline odronextamab trial in combination with CHOP chemotherapy for large cell lymphoma. This was the dose optimization part 1B results, so it's not randomized. We're just sort of seeing sort of top line data in terms of how patients did with very short follow-up, but I would love to hear your thoughts on this trial.
Yeah, I think this is a fascinating study. Olympia 3 is a randomized phase 3 trial, and we are not yet seeing the full data cut. As you mentioned, this is just the part 1B, looking at 40 patients total. So this is thought-provoking, but not yet definitive. But the bispecific antibody odronextamab binds to CD20, binds to CD3, and has an immune reaction that occurs theoretically better than what rituximab would do alone. In this trial is being evaluated of O-CHOP, if you will, odronextamab CHOP versus R-CHOP. In this part 1B, we've seen in the limited number of patients that are treated so far a very high response rate, an 85% complete response rate and 90% and 95% overall response rate in the two cohorts, respectively, looking at different doses. So the efficacy is outstanding. The problem is the toxicity. In this trial, cytokine release syndrome, having fevers, having a sepsis-like phenomenon, occurred in more than half of the patients. 55% of patients had some degree of cytokine release syndrome. And perhaps even more concerning, several patients, a small number, but not zero, had neurologic toxicity, so-called ICANS, which is a significant problem in a setting where other therapies, like we just heard, Tafa-Len, R-CHOP, don't have those toxicities of CRS or ICANS. So I'm intrigued to see the full phase 3 trial, but the complexity factor for bispecific antibodies, I think, is real, and we're going to have to wait to see if the juice is worth the squeeze. Dr. Jacobson, you mentioned we've got a lot of studies coming in frontline. We also have a novel agent called golcadomide, which is an oral agent, sort of like a supercharged lenalidomide, if you will. It's called a CELMoD. And at ASCO, we saw data of a combination of golcadomide plus Pola-R-CHP in a cohort of patients. What were your thoughts on this data set?
Yeah, so this looked very good. This was a dose finding study, so there were two different doses of golcadomide that were used. Unlike the way we've combined lenalidomide with R-CHOP in the past, or even in the frontline study, the golcadomide's only given for day 1 to 7 of each cycle, so it's a much shorter period. And it's combined in this case with Pola-R-CHP as a backbone as opposed to R-CHOP. And we saw, just about 16-month data from this trial, and certainly looked like the higher dose, the 0.4 milligram dose of golcadomide, was more effective. The end of treatment complete metabolic response rate was 82% for that group, and the 12-month progression-free survival was actually 96% for that group. Again, single arm open label study. We often see, a little bit of a downtrending in these numbers when we start looking at in a larger randomized study. Interestingly, unlike in the first study we talked about with the frontline study, where the rates of MRD negativity by CAPP-Seq were greater than the rates of PET negativity, here MRD negativity really did closely track the PET negativity using a FASCP technology at 83% at end of treatment for the 0.4 milligram dose. This did look like it was reasonably well tolerated, and they were actually able to give nearly full dose Pola-R-CHP and golcadomide with both doses. And so this drug looks like it's really easy to combine. The improvement in responses were seen across the different cell of origin for large cell lymphoma. And so, I'm interested to see how this plays out in a randomized study.
And I would just add for this GOLSEEK trial or the golcadomide trial, that the GOLSEEK-1 randomized phase 3 trial is comparing R-CHOP with golcadomide versus placebo with R-CHOP. And that trial has completed enrollment, and obviously a highly anticipated result, kind of building on this data set that we're seeing here with using polatuzumab R-CHP. That trial is using standard R-CHOP. But that's a global phase 3 trial that's already completed. And so these data of combinability and high response rates, like you highlighted here, are intriguing. I don't think it'll be that far in the future that we'll see a phase 3 trial complete and have results available that hopefully show that this agent can move into frontline outside of clinical trials for our patients with large B-cell lymphoma.
Yeah, and so we talked a little bit, I think, in a bunch of these studies about cell of origin and how the distinction becomes less important with some of these agents. But we know from the POLARIX study that cell of origin was a real determinant for how patients did. Patients with non-GCB lymphomas did significantly better with the addition of polatuzumab compared with the patients who had GCB lymphomas. Maybe it's an appropriate question to ask you because the lymphoma archetypes came out of your institution, but maybe you can tell us a little bit about what we learned from lymphomap as it was applied to the POLARIX study.
Yeah, thanks. The lymphomap is a fascinating evaluation of not looking directly at the cancer cells, but looking at the environment around the cancer cells, the so-called microenvironment, the immune cells interacting with the malignant B cells. And what was seen in a prior study from our institution looking at this in patients who were treated with CAR T cells is that there were three main archetypes, if you will, three main subtypes of microenvironments that we saw that were prognostic in terms of what they meant for their response to CAR T cells. The one that was the least favorable for treating a patient with the immune therapy CAR T cell was the so-called T-exhausted phenotype, or the TEX phenotype. And in that clinical trial, ZUMA-7 was the data set that was looked at. This was tested in many different ways, and the paper is a fascinating read if you want to learn more about the immune system. But in that ZUMA-7 clinical trial, the TEX group did not get that much benefit from axi-cel. Still better than chemotherapy, but not as much. The other two groups, FMAC and lymph node, were better in terms of their response to chemotherapy. The question then is that a story that is limited to CAR T cell, or is that something that applies to treatments in general for lymphomas? Do these microenvironments have a role to play when we're talking about other therapies like CHOP or R-CHP Pola? And so this is an evaluation using that same archetype, that same lymph node microenvironment in the randomized phase 3 POLARIX trial. And what Dr. Harkins from my institution showed in the presentation at ASCO is that these subtypes are still different. There are some differences that come out. And notably, Pola R-CHP worked well in all three of these subtypes. There was not a group that favored CHOP. All three of them favored R-CHP Pola. Most notably, the fibroblast macrophage group was better than the lymph node group, better than the exhausted T cell group. So similar to what we saw in CAR T cells, but it wasn't such a stark trend that we saw for the CAR T cells where one group seems to behave differently, implying that the microenvironment may be less relevant for chemotherapies. In the GCB subtype, which you just mentioned, Dr. Jacobson, is relevant for polatuzumab, not perhaps working as well, there was really no difference in the text group, meaning that we weren't able to see the microenvironment overcome the cell of origin. And I think, therefore, in my practice, at least, cell of origin still is a relevant consideration, um, meaning we don't necessarily use the lymph node microenvironment test yet outside of clinical trials, outside of research assays, but I still don't tend to treat patients with the GCB subtype with polatuzumab if I've got other options. When we're looking at options in the clinic of how to best manage our patients, one of those big unmet needs that we've got that is always a challenge of managing that next patient is elderly and frail patients. We did see a really nice analysis of I'd say, a fairly large study looking at elderly frail patients from our colleagues in Europe from the Nordic Lymphoma Group, evaluating a phase 3 trial called the Polar Bear trial. This is in elderly or frail patients with large B-cell lymphoma, comparing our Pola mini CHP versus our mini CHOP. Dr. Jacobson, what did you think about this study?
Yeah, I think this is a really important study. There are some patients that we just cannot give full intensity R-CHOP to for a variety of reasons. We've been giving them our mini CHOP, but we know that the long-term PFS for those patients is really around 50 or 60%, overall, and that's not necessarily good enough to even though these are older patients, not good enough for older patients. And so this was really a study that looked at the outcomes of our Pola mini CHOP to see if mini chip rather to see if polatuzumab can sort of overcome some of that kind of what you lose by dose reducing R-CHOP. And it certainly does appear that you can. So they looked at 2-year data, and the 2-year PFS was 67%. So that already is approaching what we expect for frontline large cell lymphoma, even without dose reductions. And the 2-year overall survival was 76%. So really already outpacing our historical controls. Again, we're just seeing sort of the single arm data here. We're not necessarily seeing the randomized data, but I think that it did appear to be well tolerated, and it didn't appear that adding polatuzumab to mini R-CHIP really sacrificed toxicity. So I think this will be game changing for our older, frailer patients that we can't give full dose chemotherapy to. Sort of on those lines, I want to switch gears and go into the relapse refractory setting, Dr. Westin. And, we did see some data. It was the confirmatory epcoritamab study in relapse refractory large cell lymphoma, single agent EPCO compared to dealer's choice chemoimmunotherapy, where it was either R-GemOx or bendamustine Rituxan. And this was done in the second line and beyond for relapsed large cell lymphoma. We do have some recommendations for using combination bispecific antibodies therapy in this setting, by the NCCN. Specifically, if we're thinking about epcoritamab, it's epcoritamab with R-GemOx. But we know that not everybody who is getting bispecifics in the second line can get EPCO or GemOx. So what did you think about this study and what it means for some of our patients, and who might you use single agent EPCO for based on these results?
Yeah, I thought this was a very impressive data set, and I would agree with you that there are perhaps better options for fitter patients, including CAR T cell therapy, which I know you and I both tend to use in our second line patients if we think that they can get access to CAR T cell. But a lot of patients, for various reasons, can't get access to CAR T cell. And so this is an important data set. It showed a very nice improvement in the progression-free survival, a hazard ratio of 0.74. An improvement in the duration of response, 37 months versus 6 months. Overall survival was not different, but this was done during the pandemic. And so there was more COVID-related deaths in the experimental arm versus GemOx and bendamustine. That might be real because of the immune suppression, but that could also be something that we don't see when we're not in the middle of a global pandemic. So I thought this was an important data set that shows that EPCO by itself is still highly effective and better than GemOx or BR. I think GemOx and BR should not be used for our patients with relapsed large cell if they've got access to a treatment like EPCO. because of the improvement in progression-free survival. As to which patient would I give this? Somebody who can't get CAR, and I don't think could tolerate a combination of bispecific plus something else. Somebody who's frail, somebody who's got some challenges where a single agent bispecific might be attractive. I think that could be a good option for them. And it's nice to see this as a positive phase 3 trial. In the last minute or two, we saw two really cool new CAR T cell products. Obviously, we just mentioned that CAR T cell is the preferred approach. CD19 targeted CAR T cells have changed the algorithm for large B cell lymphoma, but we're always looking for newer approaches. Dr. Jacobson, what did you think about Vispacel and then an even newer CAR T cell product called LB2501?
Yeah, so I'll be very brief about these. These are really sort of niche trials. Vispacel is actually an allogeneic CAR T cell. So these are donor-derived T cells. So these CAR T cells are engineered from a donor. They're available off the shelf. It really does solve a lot of the logistical problems and some of the difficulty with getting patients to CAR T cells when you have to collect their own T cells and then bring them back for their treatment. These are also available on demand, so patients who are rapidly progressive can get these. And this is really, there's a number of ways that these cells are modified in order to not cause graft versus host disease and to not be rejected by the host. But the bottom line is this is really, I think, one of the more promising set of results for allogeneic products. They looked at it in a 22 patient large cell lymphoma cohort in the second line, and they actually saw CR rates and PFS rates that really mirror what we see with autologous CAR, which I don't think we've really seen before with allogeneic CAR. So the CR rate was 64% and the 12-month PFS was 51%. So that was very promising for me. It was a safe CAR. They do use enhanced lymphodepletion, which means higher levels of chemotherapy. So there was some infection and cytopenias on this study, but I think, you know, this product may have some legs to move forward in a very crowded space. But even more exciting than an allogeneic off-the-shelf CAR is that we're actually moving into in vivo CAR, where you're not actually making the CARs outside of the patient, but you're actually injecting the transgene either, you know, with a lentiviral vector or with nanoparticles directly into the patient, and the transgene is targeted towards T cells in vivo, and the CAR T cells are made that way. And we saw our first example of this in lymphoma with the LB2501 study from Legend Bio. We saw that there were 12 patients treated, but only 6 patients treated at dose level 2, which is where they saw all the activity. But they saw a 100% response rate and an 83% CR rate. Really short follow-up so far. But they are seeing some durability of response. Obviously, that's going to be the major question here. It was well tolerated. They called it CRS, but I think most of the patients are actually having infusion reactions to the lentiviral vector. But otherwise, you know, this looked like a safe CAR. So I think this is the beginning of probably the next chapter in CAR T cell therapy. And I'm really excited to see what future trials bring.
Excellent. Me too. I think that was a very cool in vivo abstract, and look forward to see where the future goes for both of those novel products. Thanks for listening to this episode of Podium Perspectives.
Follow and share to stay current as new data comes out. This episode is for educational purposes only and not medical advice. See you next time.
Thanks for joining Podium Perspectives, powered by Vaniam Group. This episode is for educational purposes only and is not medical advice.